Now, there are many different models of integrated or collaborative care that have been demonstrated over the past 30 years. These models, they're available on SAMHSA's website, which you'll see at the end of this presentation, because SAMHSA has really been invested in making as much information about different models, and they actually have treatment. They actually have employee manuals. They have different kinds of things with different kinds of steps that you can take to implement integrated healthcare, and so they really have been proactive about that. Many of the models that have been written have involved psychiatric nurses in the development and implementation, and I take my hat off to the early pioneers, especially at Impact out in Washington State, and the Diamond model up in, I think it's Wisconsin. But there's a bunch of different models that are excellent. MacArthur Foundation screened for depression healthcare as well early on, and those are all available, and they provide a core of models that you can choose from that address the different complexity presented in different types of primary care involvement.
Can we talk a little bit about the levels of care that people will be requiring as they come into these integrated care facilities? Certainly, we're going to have different levels of acuity, and I wonder how these models will address those needs.
Yeah, you have to take a look at the levels. Not everybody wants, a full press of psychiatry, insisting that you take an antidepressant. The first thing that you have to do is you have to do preventative services and screening. And in primary care offices, they've been strongly encouraged for the last 20 years to do a PHQ-9. It's been revised a little bit. A lot of people are using the PHQ-SADS or some other psychometrics. Sometimes they just use a PHQ-2, which just asks 2 questions. PHQ is Patient Health Questionnaire. But that is something that the primary care doctors tend to ask 1 or 2 questions, and then they go on to the full 9 if they really want to do a full screening. And if they want to do anxiety screening, they use the SADS as well. And that really identifies different types of patients that and what they need to do, and also see if it actually interferes with their health care. Level 1, which is early intervention, so if they screen positively on the PHQ, then they do a brief assessment, and then people are supported for giving additional resources, given a name of an access to a mental health provider, or a warm handoff. What we do is we actually, if a primary care doctor actually sees that, okay, you seem to be depressed, let's have somebody do a further assessment. So our behavioral care manager, who in this case it isn't a BSN, it's a bachelor's level mental health provider, comes in and actually takes more of an intake, and that's usually done in the primary care office. Sometimes the primary care physician himself or herself does the brief assessment. It's not necessarily what they think they really love, but at least it takes away from their medical analysis, and it goes more into the mental health. But it does frequently lead, when the primary care physician or providers do the PHQ, it does lead to them offering a psychotropic medication, when in our realm we would be offering, let's talk about psychotherapy and get you in touch with the right provider to do the right assessment, and let's further where we're going. The level 2 is the specialty consultation and treatment and coordination. And this is for patients who have more immediate or somatic level of mental illness and require more psychiatric or behavioral interventions. And this might involve a more advanced evaluation of the cause as well, because not every depression is because of depressed mood. It could be because of labs. It could be like thyroid or diabetic control could be causing it. It could be because of another problem, a family cycle problem. But the end result would be leading to a treatment plan that would detail psychotherapeutic interventions, education, and psychiatric interventions. And sometimes that's when once we do a full evaluation or full consult, that's when we produce a consult note and a treatment plan and care coordination. So that's in level 2. Then we go to another level, which is level 3, which is more intensive mental health services for complex chronic problems. And this is usually done outside of the primary care environment. we usually refer a patient to, with higher complexity than what's just handled in a primary care office, to a mental health provider. And that doesn't have to be my office. It can be somebody else's office down the street. It can be a hospital. It could be a psychiatric intensive outpatient. It could be something else. Or it could be to my collaborating psychiatrist to do a little bit more of an ongoing assessment of memory loss or whatever that's more acute. But this links patients to community-based psychiatry, and a lot of patients need that. There's community support groups for a variety of mental illnesses. In our area, we have a bipolar support group, and we like to link patients to that because it's free, or it's low cost. They give a donation, and they meet other people, and the same thing is true with AA, NA, CHAD, which is for attention deficit disorder, but there's other community-based services that we can actually refer people to. Plus, we can refer them to county support. We can refer them to the behavioral health evaluations for developmental disabilities, or the school districts, we can refer to them. Psychologists can do more of a learning-based and ADHD documentation that we don't have to do in the primary care environment or in the outpatient clinics that we run. The other thing about the third level is that we do care coordination between those resources, and we develop a treatment plan that doesn't necessarily tax their healthcare dollars, nor does it tax the primary care time. So that's something which is very, very key to cost effectiveness, and the providers of that really encourage that, and it's nice. And the higher levels than that would just be to refer to to triage into a psychiatric hospital, which I didn't even cover on this.
I certainly think you're sparking an interest in the audience about what integrated care can be. In order for us to really understand the principles involved here, I was wondering if you could talk a little bit about terms that people actually need to understand in order to fully grasp this model.
Yeah, I hope that people understand that they can do this model, that this is something which they can set up. You don't have to ask permission. You can set this up. We can talk about how that works later. Even we can do this online through the member bridge. But there are key principles that you need to understand. Okay? The first principle is that it's always family-focused. We've changed the focus now. We've changed it from individual behind closed doors, acting as if it's only them. Mental illness affects everybody. You never see the patient necessarily as alone in this world. And you need to see what environment, what family they can actually call upon to help them manage their own care. The second thing is professional collaboration. We work with other professionals all the time. We have to identify that collaborative team. And that collaborative team might be in the primary care offices, or it might be distant. It might be that they go to a specialist somewhere else, an endocrinologist, or a rheumatologist, or even they go to AA. And that's professional collaboration. The third thing is that we really have to go back to our old basic psychiatric nursing, in which we actually do care plans, okay? Because that really is the backbone of our profession, of nursing. And we have gotten away from that into more of a psychosocial and psychologist-based program. But the key principle that comes back out time and time again, and this comes from resources out there, they're trying to tell even psychologists, you need to develop a care plan, and then you have to also then make sure that the care that you suggest is then followed through with care coordination. And then don't forget to educate the patient. A lot of patients need to understand their side effects of their medications, so that they know when to call you, or they also need to make sure that they get additional monitoring. We have a lot of patients who are on mood stabilizers that need consistent monitoring, and some of the atypical antipsychotics especially have to get monitored for some of the more significant side effects and with blood chemistry that are invisible. And this is how we prevent the mentally ill from dying 25 years younger than their peers.